This is the LPN to RN class, and they are going to talk to you guys about wound care.
Okay, so we have two different type of wounds, major groups of wounds. We have acute wounds and then we have chronic wounds. Acute wounds are those wounds that are able to be healed over a predictable amount of time. Your chronic wounds are going to be those wounds that are over a longer period of time. They don't heal as quickly. They could be there for months upon months. Wounds can be open or they can be closed. We have non-penetrating wounds and then there's penetrating wounds. Both of those can fall under surgical trauma or pressure injury. Some of your non-penetrating wounds could be abrasions, lacerations, contusions, a concussion. Penetrating wounds may include a stab wound, skin cuts, any surgical wounds that have been made, and a gunshot wound. So the pressure ulcers, that's a localized injury to the skin or underlying tissue. That's usually over like a bony prominence as a result of unrelieved pressure. That can be anywhere like on the hip bones, the knee, ankle, heels. Those are some most common areas. A surgical wound is obviously going to be a cut or like an incision made. Like if someone had heart surgery, that can be a surgical wound. And then trauma is going to be your wounds that obviously were not intended to be there. It could be from a motor vehicle accident. It could be just from a fall. Anything traumatic. It's a severe break or injury in the soft tissue of the skin. Like I said, it can include abrasions, lacerations, or crush wounds. There's also miscellaneous wounds. Those can include thermal wounds, chemical, bites, stings, electrical wounds. We also have some venous ulcers that you can have. Peripheral artery disease can also cause wounds and ulcers. Some risk factors for wounds is children, elderly patients, any hazardous environment, chronic illnesses that may not be managed well, like diabetes, poor nutrition, immobility, cardiovascular disorders. For your older population, incontinence or not able to control their bladder can be a cause for a pressure injury. Poor hygiene, medication abuse is also another risk factor. So some causes of different wounds. I talked about vascular disease, so like in the cardiovascular system, that can be a cause. A sedentary lifestyle, diabetes again, they can have wounds on their feet and not know about it. And then burns is also a big cause of pressure injuries, trauma. And then another cause that we see a lot of is necrotizing fasciitis. That's the bacteria eating disease of the flesh. And so nursing intervention wise, to help prevent wounds, you want to make sure that your patients have a proper diet, good hygiene. You want to make sure your patients are moving, and not just patients in general, but elderly, anybody can develop a pressure ulcer or a pressure injury. So good movement, repositioning frequently. Managing our chronic conditions is very important for our elderly population, especially those with diabetes and cardiovascular disease. Maybe people who are paraplegic or are paralyzed, don't move around a lot. And then proper medication regimen. That's also important for preventing wounds and for treating them. Dietary changes wise, protein is really good for healing wounds. Some good protein is eggs, milk, cheese, Greek yogurt, soy nuts, tofu, beans. Really, those are really good wound healing proteins. So, Jessica.
Alrighty, I'm going to talk about pressure ulcers because they are the most common wounds. They are also called decubitus and bed sores. They are a localized area of dead tissue caused by pressure, friction, shearing to the skin, and is a breakdown of skin and tissue damage. This happens when there is pressure to an area of the body and the tissue is not getting oxygen and the tissue starts to die. These areas are usually over bony prominences, which are the bony areas of the body. For example, the coccyx and the sacral area, which is the tailbone, elbows, heels, hips, spine are all bony prominences. You usually see this in elderly or paralyzed patients due to poor nutrition, lack of mobility, and not able to reposition themselves. So to prevent pressure ulcers, you would provide good nutrition, assist with repositioning and mobility, and a high-protein diet promotes wound healing. There are a number of risk factors, diabetes being number one. You have obesity, poor nutrition, poor oxygen in the blood, and poor mobility. There are many others, but those are the top 5. The expected findings of a pressure ulcer could be, it starts as a red area that stays red, or it could turn into an open area with different stages of tissue death, which means each stage means a different level of tissue death, and the deeper into the skin could go all the way to the bone. Lab test would be a wound culture and sensitivity. This would show an infection, which bacteria is causing the infection, and the sensitivity test would be which antibiotics you would prescribe for that specific bacteria to help with the healing. A person with a pressure ulcer may possibly need surgery to remove the dead tissue, and in severe cases may need skin grafts. Complications from pressure ulcers are the patient could end up with a secondary infection, could become septic, which is blood poisoning caused by bacteria or their toxins in the blood, or it could turn into gangrene, which is death and decomposition of body tissue, which could result in amputation. Nursing homes and hospitals use the Braden scale to predict pressure ulcer risks, which this is our Braden scale here, which is what we use. This tool is to help health professionals, especially nurses, assist a patient at risk of developing a pressure ulcer. And it provides information such as sensory and perception, moisture, activity, mobility, nutrition, friction and shearing, and it goes with the different stages of if you can do it all yourself or if you need assistance in those areas. And that helps us determine the risk factors. And then we need to educate the patient on the causes of pressure ulcers, what to do as far as treatments for the pressure ulcers, because different stages require different treatments. We need to educate the patient to watch for signs and symptoms of infection or in healing, so we need to let them know what the body's supposed to look like as it heals and then what to look for as far as infection goes. We need to teach them on how to prevent new ulcers, for example, change positions frequently, do range of motion exercises, which increases blood flow to the extremities. And range of motion exercises is basically moving your joints, like your elbows and your wrists, to get the blood flowing. And that is a pressure ulcer in a nutshell. I'm done.
Alright, so I'm going to start with some definitions of things that I'm going to be mentioning. The first one is eschar, which is dry, scabby appearance to the skin. Slough, which is dead tissue that is shedding. There's also blanching, and that's when you press on a wound, the skin turns a lighter shade, and then when you release the pressure, it either returns to the normal color that you saw before, or it does not change. The epidermis is the outer layer of skin. The subcutaneous layer is the layer that's just below the outer layer of skin. There's undermining, which is the outer skin is separating from the subcutaneous layer and it forms a pocket. Tunneling is a wound that goes through layers of skin, obviously forming a tunnel. And then the sinus tract is a narrow opening that extends from the wound in any direction and creates an abscess. Indications for staging a pressure ulcer is to create a treatment plan that will help in the healing process. And then before performing the staging process, we would administer pain medication, provide privacy, and have some of the following items with us. One is the sizing chart. And then there's also a ruler, a camera, gauze sponges, medical tape, cotton tipped applicators, which look like this. And you can actually use this to determine the depth of the wound and how far the tunneling goes under the skin. And the medical drapes, and then a pair of gloves or two. And then you evaluate the wound to see if it's getting better or worse. And if it's getting worse, you can come up with a different plan to treat the wound a little bit better, see if it would work better, sorry. And then there are 5 stages. The first stage is where the skin is intact. And then if you are light skinned, there's a reddened area that you would try to put the pressure on it to see if it blanches or not. If you have darker skin, it's a little bit harder to see if there is an actual pressure ulcer. So what you would do is you would pick an area that's away from the spot that you think the pressure ulcer is going to be at, and you look to see if there's a different color, if it's darker or lighter, if there's red, blue, or purple bruising. Then here on the toe, that is going to be a stage 1 pressure ulcer. And then stage 2, the skin is not intact. There's a partial thickness skin loss of the dermis, which is the outer layer. It can be superficial, and the character of it would be like an abrasion, a blister that is either open or it's closed with fluid in it, or there's a shallow crater and there's no bruising. Right here on the foot would be stage 2. You can kind of see there's a little bit different on it. And then stage 3, is loss of full thickness. The subcutaneous layer or tissue may have damage or necrosis. The damage does not go through the fascia or expose any bone or muscles. The depth varies based on location of the ulcer. And then undermining and tunneling may or may not be present. And then stage 4, this is stage 3, right here. And then with stage 4, there is full thickness skin loss, and you will have exposed or palpable muscle tissue, muscle, bone, or tendon. It often includes undermining and tunneling. Sinus tracts may develop, and then the slough and eschar is often present on at least part of the ulcer. And stage 4 is this here on the heel. And then the 5th stage is actually an unstageable stage, which there would be full thickness skin loss, and the base of the wound is completely covered with the slough or eschar, and it obscures the true depth of the wound. And then client education would be teaching the client and family to look for signs and symptoms of infection, teach them about ways to prevent the pressure ulcers by changing position as much as possible, the correct application of prescribed treatment supplies, and how often to change them, and proper diet.
Okay, next we're going to come over here and they're going to show you some other cool things.
So today I'm going to talk
talk to you guys about medication, which is Dilaudid, which you would pre-medicate your patient before you do wound culture or a wound dressing. Dilaudid is a narcotic analgesic, which means pain reliever, and that controls mild to moderate pain. So, and before you give any of these medications, you want to check your medication administration rates, which would be check the dose, the route, the patient, and the time. You want to make sure that you give this because it can be very painful to do a wound dressing without any medication. You want to monitor their vital signs and continue to monitor their pain after you've administered the medication, and watch for respiratory depression because that can happen anytime you give a narcotic. You can watch for some contraindications or precautions before you give a medication like this. It'd be an intolerance to opiates, having COPD, acute bronchial asthma, having any sort of respiratory issues could be contraindicated in giving a narcotic medication. And you always want to tell your patient not to wait until their pain is out of control before they ask for it. They need to ask for it at the onset of their pain and avoid any alcohol or any other CNS depressants. And now I'm going to show you guys how to culture. You would sanitize your hands and then lots of gloves. Make sure you have your swab. Take your Q-tip. You want to start in the middle and work in a circular motion all the way around the wound. Once it's done, you don't want to touch anything. You want to insert it right into the tube. Make sure proper labeling, insert it, and send it off.
All right, and then I'm going to demonstrate a basic wound dressing change. So I would sanitize my hands and put on a pair of clean gloves. And we'll start with cleaning. So you'll take some gauze, and this is after the wound has been measured and evaluated. So you'll wet some gauze with normal saline. You'll start from the center and work your way out so you don't introduce new bacteria from the outside. And pat dry. And so we're doing a wet to dry packing dressing change. So you'll wet this gauze here with some normal saline. And you will actually change your gloves out to put on the clean dressing. Start the packing process here. You'll pack it in pretty tight. You don't want the wet dressing change to touch the outer skin because that could cause skin breakdown. We don't want that. Just pack it in there. Cut off the excess here. And we will cover it with an ABD pad. Make sure it's all covered there. Tape it down. You will want to take a pen or Sharpie to put your initials, date and time on the dressing. right, and that's a basic dressing change.
We're gonna demonstrate putting on a wound vac. So we'll start with Veronica.
Hi. The first thing that we would do is to use, go ahead and sanitize our hands, put on clean gloves. We're gonna start first by measuring the wound. So we will measure the wound lateral first, and that is showing at 17.5. And then we're gonna do the width of the wound, and that is showing at 14.5. And then we'll do the depth, and you can do it with a ruler or the applicator. And at this time, we're using the ruler, and that's at 2 inches, okay? And then we will take a skin prep, and we will go around the outside of the wound, prepping the skin so that the tape will adhere to the skin. And then you would do that a few times and have it ready.
So we're gonna take tape and we're going to put completely around the wound because we're gonna be putting this foam on, and you don't want the foam to touch the outer edge because it can break down. So we'll start here. Go completely around. Some more. So this is the foam that'll be set in the wound. You can trim it if it needs trimmed to fit. So this is like a Tegaderm or a clear tape slash dressing. So open this. They're numbered. This is side 1, so you know to peel this first. Let me hold this side. And then this is placed over the foam, held down. You do want it to be overlapping quite a bit.
Make sure it seals.
The second side and all of the blue, and then you take your scissors and you would make a small cut in the Tegaderm. And this is what is connected to the wound vac. So we'll peel this off and place this over the part we made. And then this peels off. And then you power it on. And it'll have a countdown. And then as soon as it's done counting down, this sections and you are done.
We're going to be talking about what a normal healing wound will look like versus what a non-normal healing wound would look like. So I'm going to start with the phases of wound healing. So when you first have an injury, you go through what is called the inflammatory phase. That is where you'll immediately see redness to the side, you'll bleed for a little bit, and then the bleeding will stop, and that's your body preventing you from having excessive bleeding. And after this, you're gonna have the proliferation phase. This is where you're gonna have a scar form, and white blood cells are gonna come in and fight infection that's in the site. And then this lasts about 2 to 4 weeks, and after this phase is finished, you're gonna have your maturation phase. In your maturation phase, you're gonna have a mature scar tissue form, and the scab will go away, and you might have scar tissue there depending on how deep the wound was or what kind of injury you had.
If the wound healing becomes impaired, which may be caused by just normal defects in the tissue response process, lack of treatment or poor treatment of a wound, there are a couple things that can happen. A hypertrophic scar can form, or a keloid. A hypertrophic scar is basically a large reddened area, thick scar tissue that goes over the scar. Keloid is basically when excessive collagen forms in a wound and it can grow out beyond the wound base. It often has like a claw-like extension. Common places for keloids formation are earlobes, shoulders, upper back, and the interior chest. There are several causes of non-healing or improper wound healing: poor circulation, infection, edema, inadequate nutrition, or repetitive trauma to a wound. There are several types of treatments for non-healing wounds: topical wound medication, specialized dressings, compression wraps or stockings, antibiotics, hyperbaric oxygen therapy, basically where a person gets into a chamber and oxygen is delivered to help in the healing process, debridement, which Misty's going to talk about, and ultrasound therapy.
Okay. The purpose of debridement is to remove debris, eschar, and necrotic tissue from the wound and promote wound healing. The first thing you want to do before you do any type of debridement is to administer pain medication and clean the wound. There's a chemical debridement, which is we put an ointment on there to help the process. There's a surgical debridement where they use instruments such as a scalpel, and mechanical debridement where it's we use like a wet to dry dressing, and the dressing is applied wet and then removed dry. After we do any type of debridement, there's a dressing that's applied on the top to keep the skin, to keep everything kind of working right. The purpose of that, what we want to do is keep that clean and dry through the whole process. We want to relieve pressure from the wound and also change the diet to include protein. Complications of this can be infection or skin maceration, where the good tissue around gets too moist, and then obviously pain can be an issue. Nursing interventions basically is to protect the exposed good healthy tissue with the dressing, and then do any lab work that would include like protein levels. And the goal of debridement itself is to get the wound to be, clean, slightly moist, with minimal bacteria, and that the wound needs to show progress in healing.
So when we're talking about debridement, so you have a wound like this, and you have what's called slough. It's this white tissue in here. When they go in and do any debridement, they're going to go in and remove any black tissue, yellow tissue, whatever, and that's going to allow the wound to heal in the way that it needs to.
Sometimes a wound may an acute wound may turn into a chronic wound if one of the stages of wound healing are interrupted, if bacteria enters the wound, if necrosis forms around the wound, or if there is excessive moisture. Causes of chronic wounds may be neuropathy, diabetes, poor venous circulation, or immunity issues. Types of chronic wounds: diabetic foot ulcers, pressure ulcers, venous and arterial ulcers.
So with a healthy, normal healing wound, you're going to want your wound base to be more of like a pink color. You're not going to want it to be white, green, any abnormal color. You want it to be red, pinkish colored. You're going to want the surrounding skin to be your normal skin color, maybe slightly pink. You don't want it to be swollen or red. That could be signs of infection. You don't want to have any abnormal drainage coming from it. That could also be a sign of infection. You want the temperature around it to be normal. You don't want any abnormal odors. You shouldn't smell anything coming out of your wound. And it shouldn't take an abnormal amount of time. If you have a wound that is staying there for an obscene amount of time, you definitely need to go see your doctor, especially if it's a wound that is a big wound. I would go see the doctor because they can tell you exactly what should be going on with it.
Alrighty, now we're gonna open up the floor to Q&A and you will see us hop on live.